that. Now let me turn this over to Jack, who will introduce our speaker and facilitate the conversation, our first conversation.
Thanks, Ann, and thanks, Noah. Thank you all for joining us today. I'm very, very excited to introduce this first speaker, Dr. Katrina Donahue. When I saw this study come out a couple years ago, I was so excited about it because it was one of those that actually could change the way we practice. And so it was exciting to see, and I'm very anxious to hear what she has to say about it. Dr. Katrina Donahue is a family physician, a health service researcher, professor, and vice chair of research in the Department of Family Medicine at the University of North Carolina, Chapel Hill. Go Jayhawks. She has extensive experience working with community-based practices on improvement projects and implementation of care systems. Her current work really focuses on comparative effectiveness research, practice redesign, and chronic disease care and prevention. She led the PCORI-funded project that evaluated self-monitoring of blood glucose in patients with non-insulin-treated type 2 diabetes. And little known factoid about Dr. Donahue, in her free time, she coaches Olympic weightlifting, CrossFit, and occasionally competes. So Dr. Donahue, please take it over. And I think Noah will be advancing your slides.
Thank you, Dr. Westphal. Can everyone hear me? Thumbs up. Okay, wonderful. And thanks again for inviting me to the PCC Lunch and Learn. Okay, I think this is everyone that's presenting. Okay, so I'm gonna talk about our publication, as Dr. Westphal noted, on glucose monitoring in patient and provider outcomes and non-insulin treated diabetes. Next slide. In terms of disclosures, as also mentioned, I was the PI for the MONITOR trial, which is this trial that I'm going to talk to you about today, funded by PCORI. Next slide. Okay, so here we're going to talk about the MONITOR trial in terms of our objective. But first, a little bit of background. So glucose monitoring, the guidelines have been inconsistent regarding the role of glucose self-monitoring in adult patients with non-insulin treated type 2 diabetes. And recommendations from healthcare providers have varied widely on this. In addition, there are numerous stakeholders with an interest in this debate. Next slide. So SMBG, or self-monitoring of blood glucose, it's been widely practiced with patients with diabetes since the 1980s. The benefits are well established in type 1 diabetes and also with type 2 diabetes on insulin. However, for people who have type 2 diabetes and are not on insulin, the glycemic benefits are minimal at best. It could improve self-efficacy, but there are potential obstacles with glucose monitoring in terms it's invasive. It costs money. There have been some studies regarding depressive symptoms with glucose monitoring as well. Next slide. So based on this background, we engaged a group of stakeholders engaged in diabetes. So basically diabetes advocates, patients, providers, glucose monitoring manufacturers as well. And we asked them, hey, if you're going to design a study looking at this question whether you should test or not, how would you design the study and what outcomes matter to you? And thus the MONITOR trial was born. So in this trial, we looked at 3 SMBG testing approaches over 1 year. This included 450 patients with non-insulin treated type 2 diabetes that were regularly seen in primary care practices in Central North Carolina, 15 practices in Central North Carolina. And we randomized them to 3 arms. The first arm was randomized to no glucose testing. So we basically said, congratulations, you've randomized to no testing. Go ahead and throw away your glucometer, continue to see your regular primary care clinician like you would normally do, and we'll keep tabs on you for the year. The second group we randomized to once daily glucose monitoring. So we gave them a glucometer, and basically we instructed them to test their blood sugars daily. and the glucometer, as typical glucometers, would give them would show them the number. If they forgot their glucometers at their regular clinician visits, the clinician could actually download the glucometer readings from the cloud, and we just instructed them to continue seeing their providers and do what they would normally do in their regular diabetes care. Group 3, we randomized to once daily glucose testing, so gave them a glucometer, but this one we decided to program it. We programmed it with tailored messages, so every time they would test or prick their finger, they would get a message of either giving them encouragement or just depending on what, encouraging them to call their physician if their blood sugars are running high, those sorts of things. So basically, there's a picture here of a guy testing his blood sugar, gets a reading, and then we programmed a little message, a personalized message. Next slide. So in terms of who was in this study, these patients were typical primary care patients, age 30 and over with type 2 diabetes, not on insulin. Their A1C ranged between 6.5 and 9.5. The reasoning for that range is if it was over 9.5, at that time that's a person that you'd be thinking about insulin and then testing as well. English-speaking patients as well as non-pregnant patients. Our outcomes based on our stakeholder input, we powered on 2 outcomes. We powered on change in A1C or glycemic control over 1 year and health-related quality of life. We also looked at secondary outcomes, diabetes-related quality of life, treatment satisfaction, communication between patient-provider, healthcare utilization. We monitored through the EHR in terms of ED visits or urgent care visits, and then whether or not they changed their medications, as well as potential harms of hypoglycemia. We monitored for that as well. Next slide. So this is just a slide showing some of our baseline characteristics of our population. Typical patients, average age 60. They were obese with BMI between 33 and 34. These patients had established diabetes in general 7 to 8 years, but 10% of our population were newly diagnosed. And over 3/4 were testing their blood sugars prior to enrolling in the study. So they had some exposure to blood glucose testing. Next slide. So we followed them for 1 year, and at the end of 1 year, we found no significant differences in glycemic control among our testing and no testing groups. So basically, as you can see from here, the first column shows the baseline 1 year follow-up and their change, and the next columns are no testing, testing with no messaging, and testing with messaging. And you can see maybe the testing groups a decrease of A1C of 0.05 or 0.1, but again, not statistically or even clinically significant. There were also no significant differences in quality of life. Didn't get any better, it didn't get any worse among the groups. Next slide. While looking at our secondary outcomes, we could not find any significant differences in secondary outcomes. So in terms of their symptoms, their efficacy or empowerment, treatment satisfaction, their communication, there was a difference in self-care activities just because our testing groups were testing. so that's why they responded that they were testing. So that was an increase in self-care. In terms of adverse events, we had no study-related events among the groups. And I think also one thing to note here is that we had pre-specified some subgroup analyses, and we looked at that as well. So we also found no differences in our subgroup analyses, and that included, we looked at, well, what about patients with prior experience with blood glucose testing, or duration of diabetes, or baseline degree of glycemic control, or being on a sulfonylurea, or age, race, ethnicity, health literacy, comorbidities, and we found no significant differences in those subgroups as well. Next slide. So in terms of limitations, as you saw with our population, many of our patients had been testing prior to being enrolled, so it's more of a test of continuing versus initiating monitoring. However, 10% of our population were newly diagnosed patients. Another thing to keep in mind is not all patients adhered to the group that they were assigned. We checked for that as well. However, when we analyzed on just intent to treat versus per protocol analyses, there was no differences in outcomes as well. Patients belong to a UNC-related healthcare system. And finally, more importantly, these findings do not apply to patients that are on insulin. Next slide. So, summary, over the course of a year, there are no clinically or statistically significant differences in glycemic control or quality of life between patients with non-insulin-treated type 2 diabetes who perform glucose monitoring compared to those who do not perform glucose monitoring. And additionally, our tailored feedback provided with messaging via the glucometer did not work, which was a surprise to us, but it did not provide any additional advantage in glycemic control, at least for this population. And that's a picture of some of my team and stakeholders that were involved in the project. And thank you.
Wow, thank you very much, Dr. Donahue. That was terrific. I haven't seen any questions yet. I've seen some people saying, wow, this is cool. This is awesome. Love it when research confirms what I believe in my practice. And evidence trumps or is better than anecdote, typically, or we want it to be. So I thank you for doing this. I'm going to take the facilitator's prerogative and ask you the first question as we get going. And this is a two-part question. So I'm curious, what does this research mean for a team-based primary care practice? And the second part is, what does this research mean for primary care policies, such as payment, etc.? So two parts, give it a whirl.
Okay. And so what does this mean for team-based primary care practice? That's a good question. I think when we, so after we found our results and our study actually builds on pre-existing results in this area. So we felt, hey, we need to share these results to other practices. And when we talked with practices about, well, who's getting the requests for filling test strips? So it's not necessarily the clinician or the doctor that's getting those refills, right? Sometimes it's someone else on the team that gets those refills. So really, I think for this study, what we're learning is you need to get buy-in from the entire office. So if a patient, if you have a patient with type 2 diabetes, not on insulin, and they want to get their test strips refilled, and you want to ask them a little more questions about that before going ahead and just refilling them. It's good to have some of the other people on your team, your nurse, your medical assistant, whatnot, who's receiving these calls, and before they just outright refill strips. That's something we've learned with trying to disseminate our research, that you need to engage not just one person, because it's a team that's involved. So your second question, shoot, I can't even read my handwriting.
That's okay. Skip it. We're gonna, because there's several other questions that I think are also important and interesting. Did you adjust for any change in oral therapy? How did you adjust?
Oh, okay. So we did. So the majority of patients were on simple therapies like metformin or sulfonylurea at that time. We were knowing the theoretical risk of hypoglycemia for people on sulfonylureas. We wanted to look for that. So we did do an analysis of covariance, and we did look to see if there were any differences in outcomes among those people on therapy on potentially harms, and we did not find any differences in harms or hypoglycemia in this population.
What about regarding screening and overscreening? What is the savings if we were to stop providing test strips to this population?
That is a good question. It's, if you think about the typical testing in this population, it's covered for once daily testing for patients with type 2 diabetes not on insulin. Test strip is about $1 in terms of testing. And, you know, someone's not going to probably test every day. So on average, if they're testing 5 days per week or whatnot, it's, you know, it's a few hundred, like $200 or $300 if you're thinking about it in that way per year, which doesn't sound like much, but that's money that could be spent on things that are more value in patients with diabetes, like going to the gym, Planet Fitness, or they could be going to the local, farmer's market, maybe saving for that trip post-pandemic to go on. So it's for on the individual, it can add up. One thing I learned with this study is that there's actually a black market for test strips. I had people across the country telling me about that. But so that, that's something to be cognizant of as well.
A follow-up to that, Dr. Donahue, is there any concern that your research would lead to insurance denials for patient-physician dyads that felt like checking blood sugars in this patient at this time might be necessary, but because Dr. Donahue published this study saying it's not important, we're not going to pay for it?
Well, I don't have control over insurance companies, but we have engaged with Blue Cross about this data. So I think it's more. I can't comment on what insurance companies would do, but what we're recommending is that there are times when people with type 2 diabetes not on insulin may need to test. Maybe they've been diagnosed with cancer and they're undergoing chemotherapy and they're going to get an infusion of medication that could cause an increase in their blood sugar or whatnot. I mean, things can happen where there are situations you might want to test. So. But what we encourage is just thinking about rethink the strip. For your patient that's well controlled. Daily blood glucose testing is of less value compared to all the other things that a person with diabetes needs to do in their typical day.
Cool. So there's another question that starts this conversation around deprescribing and sort of this study will lead to deprescribing, and what's the experience of the participants, of the clinicians that participated in this study, or your hypothesis on what about patients who absolutely want to check their glucose levels, and how do you convince them to stop doing that? Or what's the experience with using the concept of deprescribing in this?
Yeah, no, it's certainly a concept. I think it's, there are some patients it'll be easy to, because they may have been testing out of guilt. Then when you tell them they don't have to, there's a lot, I don't have to test? Oh, good, I'm not going to. But then there are the patients that, have to know their numbers. But the question is that I would ask the patient is, hey, well, when you do test your blood sugar, what is it? Well, and you look at your glut, it's 120, 130. 90, 8. Well, that's it's not really changing, and also, an A1C is probably going to give us a better look at what your average, what your blood sugar control really is. The other thing is testing at one moment in the day should not determine what you eat. Interesting with our study. One of our nurses that was consenting patients, when they were talking about testing, they would some of the patients would comment that they would test and then decide what they were going to eat for the day. Like, okay, and that shouldn't, no, that doesn't mean you should go have whatever, a few slices of cake or whatnot. But so that's the one thing I would, and I think it's probably a long term, and for someone who really needs to hold on to those test strips. It's just that's the great thing about primary care, right? We see patients more than once and are developing a relationship with our patients, and it could just be something that you sort of bring up. Well, your A1C has been really well controlled. I really think you need to focus.
Well, so that leads to another question that came up. This seems like a very patient-centered question about, decreasing the need to put a sharp lancet into a person's finger regularly, and regular testing is a pain for patients And I think some of us who don't do it on a daily basis don't recognize the sort of physical pain that lancet causes every day. And so I'm wondering, but then there's clinicians who feel like they need the data. And so how did you come up with this question? Could you walk us through sort of where did this come from?
Oh, this question? Interesting. So we, I guess clinically I'm interested in diabetes, and I've been just working with some of my colleagues in endocrine, tossing around ideas, and this idea came up. Well, for this population, should you be testing? We don't know. We went out to a group of practices. So there's a group of primary care practices in a network here that we went to one of their medical director meetings and just asked them, hey, what do you do for this patient? Do you test or not? And I would say a third of people said, I don't have these patients test. But then the responses ranged to, I have my patients test. I have my patients with prediabetes test. And you could just see from the 50 responses across the room that it was all over the place. And we just thought this would be a great question to answer.
So here's a question. Recent clinical evidence suggests benefit for continuous glucose monitoring for patients with type 2 diabetes, even if they're not treated with insulin. How do you go about reconciling these different outcomes?
For the continuous glucose monitoring, for CGM, I know it's been approved for patients who, and is useful for patients with type 2 diabetes on insulin. The way I reconcile that, well, it's expensive too, but for patients who have type 2 diabetes, have very well controlled A1Cs, continuous glucose monitoring is really not necessary. I would have to look at that trial. The one thing also to note about this trial is it's a pragmatic trial, so it's like real world everyday life. This isn't a highly intense clinical setting that's where we're controlling patients. So yeah, I would have to look at that study, but at least in the last few months when we've been talking with our CGM folks, I think if you're well controlled, I don't know what the additional benefit would be.
So, this was a project you did in 15 practices in your network there, 450 patients. Have you been able to track and detect changes in practice or patient behaviors outside of the study, but now you're just sort of, it's a year and a half or 2 years after that study concluded, you're out in those practices doing other things. What have you noticed going on in terms of sort of the diffusion of the findings in your network?
I think I have noticed some improvements. So when we started the study and enrolled our patients, over 75% of patients with type 2 diabetes were testing on it or not on insulin. When we look at our current data, it's like 30% because we're trying to because after we got we have another PCORI grant to disseminate these results, and so now we're going out to practices to disseminate it, and it's they've improved so much. It's like, how much further do we need to improve? But I guess there's always room for improvement. So I guess in summary, I think it's getting out there. I will have to say CGM is also rearing its head too. So will be that'll be our next study, maybe.
So last question.
Mm-hmm.
If you could just again mention a little bit about how this fits into the broader context of primary care research on deprescribing and sort of the risks and benefits of research that says, hey, you good doctors have been doing more than you ought.
Yeah.
You patients probably don't have to do all this other stuff. Can you just finish us up with a minute or two on that, please?
Sure. There's There is a group, the Choosing Wisely campaign, which I think is very in tune with deprescribing, considering activities that may be of less value. And the American Academy of Family Physicians and the SGIM, they also are in line with this, and they're against blood glucose monitoring in this population. And it's as part of the Choosing Wisely campaign. So, but just because, so we have some primary care societies that are in favor of what we've found, but there's also differing opinions in our specialty colleagues but I will say that the ADA did note and at least cite this study as one of the pieces of evidence that in people with type 2 diabetes not using insulin, routine glucose monitoring may be of limited additional clinical benefit. So I'll use that with
that. That's a huge. I think what I would call.
Well, I would say
change.
choose wisely. Isn't that the bottom line?
Yeah.
Choose wisely.
So, Dr. Donahue, thank you so much. Thank you for presenting and for answering the questions. Thank you all for asking the questions. I'm going to turn it over to Dr. Dunklemullen and go from there.
Thank you.
Yes, thank you. Really terrific presentation. And I'm always learning a lot with these lunch and learns. So really thank you for putting this on. So I am really honored and pleased to present introduce the co-authors for the next article, which is Higher Primary Care Physician Continuity. It's associated with lower costs and hospitalization, and it was co-authored by Dr. Andrew Bazemore and Dr. Stephen Peterson. They're both here. So I will basically introduce Dr. Bazemore first and then Dr. Peterson. Dr. Bazemore serves as the Senior Vice President of Research and Policy for the American Board of Family Medicine. As Senior Vice President for Research and Policy, he is responsible for managing all the research functions, the staff development and implementation of an enterprise-wide strategy for research, co-directing the new ABFM Center for Professionalism and Value in Healthcare in Washington, D.C., and also coordinating and developing an existing and expanding leadership scholarship portfolio that includes visiting scholars and fellowships and other programs, and really expanding this to sort of a national, not just national, but international collaborative research participation in partnership. So we're really excited. He's continuing to grow his own research in measures that matter for primary care, for workforce and training, as well as access to primary health care for vulnerable populations. And Dr. Stephen Peterson, who would be chiming in, joined the Robert Graham Center in 2005. He's currently research director, both overseeing and contributing to the Center's analytical activities. He was previously a sociologist and social statistician, and was on faculty at University of Virginia in a researcher at the Southeastern Rural Mental Health Research Center. He's got lots of courses, graduate and undergraduate in statistics and welfare policy. Really talented person, and had actually earned his PhD in sociology from University of Wisconsin, and his undergraduate degree was in sociology and anthropology from Harvard College. And so we're really honored to have both of them here to talk about their study, which we know continuity of care is really the fundamental building block of high performing primary care. So the reason why we selected and excited to learn more. So I'll turn it over to Dr. Bazemore.
Thanks so much. And to you, Irene, to Jack, to PCC. This is a really important journal club. I'm thrilled to see it going and excited to present an article, and thrilled that that Dr. Petterson, that Steve could join us, and just wanted to call out his incredible contributions to understanding measurement in primary care, particularly as he is moving into a new sabbatical phase. It's been a real honor to work with him on this and many, many other projects. Should also call out that Drs. Lars Peterson, Rich Bruno, Uni Chung, who's also on the phone, and Bob Phillips contributed to this work, and we're grateful for that. And then to just call out a mistake. Noah knew that I was going to send a small slide deck, and then I didn't. And then I corrected that yesterday, and Noah, I managed to trim the punchline slides off when I sent back the trimmed deck. So I'm going to suggest we get to about slide 5, and then we wing it, and we come back so that we can all look at each other as I talk through the study. But I'll give a little background, and also pause later to let Steve weigh in. We can go to the next slide and just tell you that we set out at this. Anytime you're presenting a study that's 3 years old and probably represents 2-year-older work, it's amazing how your thinking progresses, and you certainly learn a lot as you continue to do work in the same space. But just wanted to set the groundwork. We were out to try to better understand a core function long described as important to explaining the benefits of primary care: continuity. It's been described in many ways. I think Jeannie Haggerty in saying this is an implicit contract. It's something that is implied in the relationship between physicians and patients. And it's part of what we in primary care assume an ongoing responsibility for our patients over time and space, and includes administrative components, not just the relational components. We're responsible for keeping their records together. It's what allows other features like coordination to work. And it certainly involves knowledge, trust, and respect. And we're in an age where the decline in particularly trust in the health system and in physicians only highlights the importance of continuity anymore. Go to the next slide. More broadly, we were really interested in a time where measures have, and I hope I'll see some nods on the screen, have slowly started to drown many of us in the physician world and the value-based payment paradigm, and trying to move back upstream to what are the really core features in a primary care environment that is not ideal to microscopic measurement, not suited to it well. What are the core features that explain its benefits? And you don't have to look any farther than a giant in our space who passed away in 2011, but spent 25 years really showing that you can boil down the salutary effects of primary care to 4 C's. First contact, being the first point of contact with patients, providing most of what they need in a comprehensive care paradigm, coordinating their passage through a healthcare and even healthcare to community continuum, and then providing this continuity and showing over and over again that if you could, again, demonstrate that kind of functions, you saw evidence of tremendous salutary benefits across a whole host of health outcomes. I'll go to the next slide. And so we had launched first with an attempt to take perhaps the trickiest of those 4 C's on and try to explain how to measure it. We tried to take on comprehensiveness. I see Gene Rich is on the phone and has been a partner also in trying to unpack something that's really complex and did not have a physician level measure operationalized or attached to it. So we first were able to go and try to develop 4, I think Gene might agree, we're up to about 9 or 10 different ways you could look at comprehensiveness, but de novo, and then show that you could associate those greater comprehensiveness with lower costs and fewer hospitalizations. And that inspired this study. Next slide. Oops, sorry. Yes. The gaps here were a little different. Continuity has been studied for years and years. John Saltz had a brilliant paper in 2005 summarizing the evidence for individual continuity with the physician between 1966 and 2002. We didn't need to invent continuity measures. The problem was most of the measures and most of the measurement was about individual continuity. And if you're in a value-based payment world, you're looking to pay either clinicians or their teams as represented by practices. And we needed to figure out a way to roll these up and demonstrate outcomes of the, again, clinician or team or practice measures. So operationalizing continuity in a measures paradigm was one of the goals here in the study. This is where, Noah, I'm going to suggest we just turn the slides off and I'm going to talk and let Steve join me because it skipped right over all my nice method slides. Apologies. I'll say the real aim of the study was, again, to examine the relationship between physician level continuity and expenditures and hospitalizations. We were pretty intentional in picking on policy and payer relevant outcomes. And, again, starting with Medicare was also very intentional. We were looking at cost and hospitalization at the beneficiary level. We had initially this is before we got into a virtual claims environment. We were working with a single year's claims, 2011, started with a sample of all the physicians that we could identify from the American Medical Association master file as engaged in direct patient care, folks who were really doing clinical care most of the time. Then we identified all the Medicare beneficiaries that had at least one claim with somebody in our sample. And then we pulled together all the Part A and all the Part B claims data from these beneficiaries. And then within that, we picked on family physicians and general internists. So we looked at a specific pair of clinician delivery elements. And we said, we're only going to look at those who were, label them as providing continuous care if they're providing a plurality, not necessarily a majority, but a plurality of primary care visits. We can talk about that in the Q&A if you want. We talked about, is this all care, all primary care, all outpatient care? We did a plurality of outpatient primary care visits to beneficiaries that we sampled. We didn't have to, as I said, go back and invent measures. We had to go back and figure out which were the best ones to test. And we ended up testing 4 measures of continuity. For those who know the space, I'll just name them quickly: a Buse-Boxerman measure, a UPC or usual provider continuity measure, a COC, and then there's a modified continuity and a modified continuity of care measure, and a Herfindahl index, which is really an adaptation that the economists use to talk about market share. That's my fan, by the way. Let's see if we can stop that. Sorry, can everybody hear me as my fan goes a little bit wild here? We calculated patient level primary care continuity scores first, and then we rolled up the
Andrew,
scores.
can you speak up a little bit? Because you are a little bit soft. Thank you.
Sorry about that. Is that any better? I've got a loud fan here. Ann, is that better? All right. We basically took patient level primary care continuity scores and rolled them up to physician to create a physician level score based on those patients for whom they assume the plurality of care. And then a multi-level modeling exercise where we controlled for beneficiary and physician characteristics. We analyzed the relationship to outcomes. And the beneficiary characteristics: age, gender, race, but also comorbidity scores. Physician characteristics, we were looking at year since graduating, whether or not you were training domestically, internationally, gender, and several others. We also included a rural-urban correction. And again, in restricting these to primary care visits, we made some assumptions, but we did test those in sensitivity analyses, and I can talk about that a little later too. We ended up with about 1.5 million beneficiaries who were getting most of their care from about 6,500 primary care physicians. And I've already mentioned the outcome measures. The results, briefly, were fascinating to me because you were able to take the continuity scores and display them by quintile. So you were looking at clinicians who had a continuity score ranging from 60 and below, that was the bottom quintile, to a continuity score of 83 1/3 and up, and then 3 others in between them. And we found functionally a linear relationship in our logarithmic adjusted scale. What that meant was that you had an inverse relationship for charges and hospitalizations as you went from clinicians that had the lowest continuity scores to clinicians that had the highest continuity scores. You saw declines in total allowed charges, and they were meaningful declines. For cost, it was about 15%. So you could imagine 15 cents on the dollar difference between the lowest and the highest continuity score physicians. For hospitalizations, it was even a little bit higher separation, about 16% total, as you went from the lowest quintile to the highest quintile continuity score. I should also say we ended up selecting and reporting out in this paper on the Buse-Boxerman measure. It was not because that was a superior choice. It was because the Seattle Children's Hospital had taken a first stab at putting a continuity measure into the measures environment and getting approval with the National Quality Forum for a continuity measure, actually for pediatric hospitalized patients. And that meant that if we were to take these findings and to begin to translate this into a measurement, an exercise in getting a measure approved, we had one to build on. I'll tell you that the 4 continuity measures performed roughly equally, however, and when you looked at their, again, their correlation coefficients, they ranged from a 0.86 to 0.99. They were really highly correlated no matter which measure you used. The only other things I wanted to comment on before letting Steve talk and open it up to questions, we realized pretty quickly that this was just the starting point. We have since been looking at how do we get to new dimensions of understanding the relationship between continuity and outcomes. We want to look at other ages and health status. We are currently looking with the Virginia All-Payer Claims Database, for example, at what this means in a pediatric environment in age 18 to 65, and also in healthier patients. What does this mean when you include other commercial groups, other public payers even? How about other clinician groups like pediatricians? We're trying to get to understand what does continuity at the individual clinician level mean up to practice. We know that a lot of the interventions that might improve continuity would probably be at the practice or system level. We're also trying to adapt to new outcomes. We'll begin to study continuity's relationship to diagnostic excellence in certain disease categories with an upcoming grant. Also preventive outcomes and clinical outcomes. The ABFM team, if you're wondering why a board would care, is very committed to measuring what matters in primary care. We see this as a source of lowering burnout, improving wellness in clinicians, also in, again, allowing robust, high-performing primary care to develop. And I think it's important for a PCC group to understand how important this is in the PCC's paradigm for the shared principles of primary care, which clearly emphasize continuity as one of the 7 shared principles. Steve, I'd pause and see if you had other comments on the study before turning to questions.
Yeah, I actually wanted to jump in and say a question that I wanted to ask was your next steps in developing it and implementing no measures. And you have answered that. So we would definitely want to hear from Steve, and especially around, this study was measuring individual continuity with a clinician. And in this sort of age of team-based care, or practice level, what are some of the, should we be measuring that? And did you think about that in your thoughts, as part of, addressing the next step? So yeah, would like to hear from you.
I've done all the talking. Do you want to take that one and offer any other comments?
Sure.
But thank you.
Yeah, sorry, we were actually in the midst of major follow-up to this particular paper that focuses on practice level continuity, so that we're trying to capture the effect of patient coming to the same practice, in your terms, the same team over and over, regardless of whether they're seeing the same physician every time they come to the practice. And that I think I presented early results a couple of years ago, basically showing that both physician level continuity and practice level continuity both matter, and that there's actually advantages regardless of whether you're seeing the same physician over and over, whether you're actually coming to the same practice over and over. And that, so there's a the quote that Andrew started with about the trust that exists between the patient and the physician. Arguably, that's only part of the story. That if you come to the same practice over and over, think of a community health center where you really don't see, you see a lot of movement of physicians in and out, and it's hard for the patient to develop continuity with a physician. But that, by virtue of coming back, that the community health center might have all the records and handoffs from one provider to another that would again improve the outcomes for the patient. Staying back, in terms of Andrew's presentation, there's one thing that I want to emphasize, and this is, we've gotten some feedback about, are we doing an adequate job of addressing the heterogeneity amongst patients? So what we know is that you think about sicker patients have more visits, and if you have more visits, you're actually more likely to have a continuous relationship with a provider. So think of extremes. Someone has 10 visits in the course of a year. That's quite likely. They in the process form a strong bond with a provider. And the other extreme would be a very healthy person who sees a doctor every 3 years. Every year it's from a different doctor, and there's no. So the relationship between number of visits, how healthy someone is, and continuity. It's one way to think it's a confounding effect. If you don't control for the comorbid conditions, how sick someone is, that you might or perhaps masking the benefits of continuity. Likewise, we use the Charleston score, which is just a count of number of conditions, chronic conditions that a person has. But that even think about a diabetic patient, some of them are very healthy, relatively healthy, and others aren't. And you can use the number of visits as a further control for how sick someone is. So anyways, and once those two measures are introduced into the model, you find a strong effect, much stronger effect of continuity on hospitalizations and total costs. And that's the one thing I wanted to add what Andrew said.
I see a lot of questions in the chat, which is great. There's a lot of interest here. And there is a question from, a question from Jack about the effects of a bimodal benefit to continuity. So were you able to detect any patients for whom continuity to a clinician or a practice was not good? As my old boss used to equip, continuity may provide multiple opportunities to do the wrong thing.
So Jack, I think the most cynical response, I think it's an excellent question. Most cynical response I've gotten actually from a primary care HSR colleague when talking about continuity was making the assumption that continuity would have a unidirectional relationship with outcomes. And he quickly went, the reason I said cynical, he went to the Harold Shipman case in the UK, where long-term continuity resulted in the deaths of many, many patients of that particular GP. I don't think we're hopefully going to be able to detect much of that, that kind of individual malfeasance in a claims analysis. But I will say, I think it's a great setup for a study we're doing in the Virginia All-Payer Claims Database, where we're discovering in in care of children, you don't find the inverse relationship that we were finding in adults. Do I think that means that continuity does not have value in the care of children? No. Do I think that using claims to detect that value and hospitalizations and total cost as your outcomes will demonstrate what continuity does bring of value to children? Probably not. Do I completely agree with you that continuity with a clinician that is not keeping up with current evidence, or even worse, at risk of harming patients, is a good thing? Of course not. I think we're looking at a much broader payment ecology here, and just trying to say, at least right now in a fee-for-service environment, we're not paying for the right things or measuring the right things. We think that generally, based on individual level evidence, there is some good in continuity, and it should be, if it can be measured, rewarded in some way. And we certainly don't think we've cracked the nut with one claims measure. I hope that helps.
Yeah, there are great questions in the chat. Just wanted to point this out. Looking at continuity, was there any data regarding the panel sizes or recommendation on a preferred panel size? Great question.
Yes. I saw another one, sorry, about panel sizes. I was looking at continuity. Was there data regarding panel size recommendation? That's an interesting question. Steve, did you want to talk about, that was an interaction that you actually put into the models, looking at number of Medicare beneficiaries cared for really actually mattered to the relationship, for example?
It wasn't an interaction so much as control. So that what we're finding is actually the more patients you have, the more continuous, the more likely it is to provide continuous care to your patients. And that, and the interpretation of that is probably, again, think of the range of physicians that are out there, and that, some of them, again, are moving maybe earlier on in their career, just starting out, and that they're yet to really develop a large number of Medicare beneficiaries in their panel. And that those younger patients might have, again, it's harder for them to form this relationship because at the beginning of the relationship. Whereas the older doctors have both more patients as well as more Medicare patients, as well as more time to form continuous relationships with those patients. Does it speak that doesn't speak to the issue of optimal panel size, and that we're talking, the range was. There's actually one physician who had 2,291 Medicare patients, well, which is Medicare. And that's hard. Remember, some physicians will specialize in Medicare patients. That's all they see. Whereas a typical family physician might have 20% of their patients might be Medicare. But that, I don't think this is, I guess it's, I would not use our findings to suggest that the larger the panel, more continuous, more continuity of care. But it's an interesting question.
I would say that the study doesn't comment on that, but that there is a lot of work being done to tie that to another question about whether, well, it's back to whether it matters more to have continuity with an individual clinician, a team, a practice, or an institution. I think there's no doubt we've long known we operate in an age of primary care teams. I think, speaking personally in my clinical practice, the continuity with my MA is as valuable as it is with me, particularly as a one-day-a-week clinician. The fact that I have continuity partners, behaviorists down the hall. I have a pharmacist who helps to review and help me avoid polypharmacy and speaks very directly to my patients when she detects that. A big part of primary care continuity is no doubt the teamlet diet. It's so hard to detect that in the measurement environment because you're using claims or electronic health records to build these measures. So I'd say the reason we're teasing out this practice, not versus, but practice and individual dose effects of continuity is trying to figure out, since we can't hit the sweet spot, the team or teamlet, particularly in larger practices, can we at least discover what practice and individual clinician continuity mean? Those are the levels of payment if you're in a fee-for-service or typically a capitated environment. And I think we're discovering that small practices and solo practices obviously behave a little differently. You would predict continuity in those, and you're going to even have to begin to look at organization size as another dimension in the measurement world.
So we're at the top of the hour. This has been a great discussion, great presentations.